Hi, good afternoon, everyone. Thank you for joining us for our April Arizona Community Grand Rounds. I'm Jessica Rigler, and I serve as the Staff Vice President for Population Health and Innovation at Blue Cross Blue Shield of Arizona. I'll be your facilitator for today's session. Before we get started, I'd just like to extend my appreciation for all of the planning committee members for this event and our technical support. You guys are rock stars. Thank you so much. I'm going to quickly introduce today's panelists, and then I'll ask them to spend just a few minutes providing some initial comments on our topic today, collaborative response to the opioid overdose epidemic. Then I'll ask for a response from today's discussant, Dr. Jesleen Chatwal, and then we'll spend the rest of the session with discussion among the panelists based on questions from all of you. You can use the Q&A feature in Zoom to ask your questions as we go along. And please remember to stay until the end of this session. At that time, we'll share a QR code and a survey link that you can use to obtain continuing education credits for your attendance at this session. So as we begin, I'll start with some brief panelist bios, very brief because they all have very long and extensive resumes, as I'm sure many of you are familiar with. First, Sheila Sjolander is the Interim Deputy Director of Public Health Services at the Arizona Department of Health Services. In this role, Sheila oversees the prevention, preparedness, and licensing divisions with the agency. She's also served as the Assistant Director for Prevention Services at ADHS for the past 11 years. She oversees more than 60 public health programs, including the department's overdose prevention work, injury prevention, maternal and child health, nutrition and physical activity, primary care, and chronic disease programs. Next up, we have Dr. Sara Salek. She's been the Chief Medical Officer for the Arizona Healthcare Cost Containment System, or AHCCCS, since June of 2014. And in her current role, Dr. Salek spearheads the agency's major clinical initiatives, as well as oversees the quality and delivery of the healthcare services that AHCCCS provides. Clinical initiatives currently underway include the expansion of telehealth service delivery, improving child and adolescent preventive care rates, and addressing the opioid epidemic. And our last panelist today is Dr. Sara Gibson. She's the Medical Director and Psychiatrist for Little Colorado Behavioral Health Centers. In this role, she's provided comprehensive psychiatric services to rural Apache County solely via telemedicine since 1995. Dr. Gibson is passionate about providing both highest quality and timely medical services to underserved persons and places. She also serves as the Medical Director of Telemedicine for Health Choice Arizona, overseeing the North Central Arizona Telemedicine Network for mental and physical health care integrated systems. And then joining our three speakers today will be Dr. Jesleen Chatwal, the Chief Medical Officer at Sierra Tucson, Clinical Assistant Professor at the University of Arizona College of Medicine, and the immediate past President of the Arizona Psychiatric Society. Dr. Chatwal will provide her reflections after our speakers' presentations during the discussion section of our program. So with that, I'm going to turn the floor over to these talented individuals to give some brief remarks. Please feel free to use the Q&A function to send questions our way. And after each of the panelists provides their initial comments, we'll dive into all of the discussion. So first, we'll kick it off with Sheila.
Great, thank you. If we could bring up my slide deck, that would be great. I'm going to start by providing an overview of the overdose trends that we're seeing in Arizona. Next slide. So this is a look at what the CDC has put together in terms of all drug overdoses, drug overdose deaths in Arizona since 2017. So they're doing a 12-month rolling of provisional of drug overdose, so you get a better perspective on what's happening more recently. That top line and the black line is all opioids, and the brown line is synthetic opioids, which would include fentanyl, and that gray line is methamphetamines. So it gives you a good view of how things spiked in 2020, but has since looks like it's leveling out. So you can see that as of October 2022, we had about 2,700 overdose deaths for the last 12-month period. Next slide. And here's a look at how the CDC found which types of drugs were involved in these overdose deaths. And this is as of 2021. So you can see by far, it's still mostly opioids with illicitly manufactured fentanyl comprising nearly all of the opioid overdoses. And interestingly too, you can see a very small portion of those overdose deaths happening because of heroin or prescription opioids. And on the far right, that pretty lavender bar is the methamphetamine deaths, which are found in almost 50% of the overdose deaths. Next slide. And here's a look from our Arizona data. We see that 5 Arizonans are dying each day from opioids in 2022. The 2022 data is still preliminary, so we'll expect those numbers to increase a bit. In fact, I looked at the dashboard. We have a live dashboard this morning, and it was at 1,894 deaths occurring in 2022. But you do see it looks like it is going to go down in 2022. So some hopeful news there. Other takeaways from this slide, you can see most of these deaths involve multiple drugs, 81%. And then again, you see the significant decrease in deaths caused by heroin. Next slide. This is a look at the opioid overdose deaths by month. That black line is a rolling average, so it gives you kind of a better sense of what things are looking like, aside from the various spikes you see from month to month. The summer months, we do tend to see higher deaths occurring from opioid overdoses. So you see a spike occurred in July of 2022. But again, you can see that it looks like it is leveling off. Next slide. In terms of age groups, our largest concern really here is the 25 to 44-year-old age groups, which has been consistent for the last 3 or 4 years at least, where we've seen this age group disproportionately impacted by opioid overdose deaths. Next slide. And then I just want to tease out a little bit among children, because this has been an area of concern. Particularly, you can see the increase that occurred in 2020. Thankfully, it looks like both the non-fatal overdoses, which is the red line, as well as the fatal opioid overdoses, which is that gray line. We've seen decreases in the last 2 years among children 0 to 17. So again, a point of hope there. Next slide. And here's a look at what the non-fatal opioid overdoses are looking like. These are confirmed non-fatal opioid overdoses. So of course, there's much more than that is probably not being reflected in these data charts, but just to give you a sense, again, how it looks like the numbers that we're seeing are declining. Other takeaways from this graph on the bottom, you can see about 64% of the non-fatal opioid overdoses involve fentanyl. At least they can identify fentanyl was involved in the opioid overdose. And then we see more situations in which meth was combined with the opioid overdose. Next slide. And then this is a slide from the CDC. I like to use this slide because I think they did a really nice job of pulling out points of intervention. So from their analysis of all unintentional drug overdoses in Arizona, and this is from 2021, they found that 81% of those deaths had at least one potential opportunity for intervention. So on the right, you can see examples of what those interventions may have been, with about 34% of those folks having had a mental health diagnosis. 65% of the times there was a potential bystander present. About 11% there was a prior overdose, and then 12% the person had been recently released from an institutional setting. So I think this speaks volumes to where we as professionals can intersect and hopefully intervene and provide referrals to treatment, make sure the people that we're interfacing with in these situations have access to naloxone. Next slide. And then I just wanted to give you a sense too of what the opioid prescribing is looking like in Arizona. Since we already noted that the deaths due to opioid prescriptions has gone down, you can see that that is mirrored by a decrease in opioid prescribing as well. Next slide. And then a look at naloxone being dispensed by pharmacies. Of course, this really took off when the public health emergency was declared back in 2017. But again, you can just see the gradual increase of pharmacies getting out naloxone. And you'll all note that a person does not need a prescription, a specific prescription to access naloxone, because we do have a standing order in place through our medical director. So folks can access naloxone at most pharmacies through that mechanism. Next slide. I think that those are my comments for right now. Want to point you to our opioid website, which has a lot more data on it and more information. We have a pretty robust data dashboard that you're welcome to take a look at. And I will pass it on to the next presenter. Thank you.
Thank you so much, Sheila, for that great overview. As a reminder to everyone on the call, you can use the Q&A function to put some questions in if you have anything that popped up during Sheila's talk or any of our other panelists. I know I have some questions maybe we can return to around impacts of the approval for over-the-counter Narcan that maybe we can get into a little later. But first, let's hear from Dr. Salek.
Great. Thanks so much, Jessica. Great to be here with you all, and happy to provide an overview around some of our efforts through our Arizona Medicaid program, otherwise known as AHCCCS. And we work really closely with our Department of Health Services. And so oftentimes Sheila and I are co-presenting together her on kind of what the data trends are showing us. And if you haven't had a chance, as she mentioned, that really updated opioid dashboard on the Department of Health Services website is a really great resourceful tool that you can access directly. And so I always like to start off with kind of a recap of the role that the Arizona Medicaid program access plays within the opioid epidemic. And so, as I mentioned, we work really closely with our public health agency, the Department of Health Services. And our role specifically is around, not only providing Medicaid services, and I'll go a little bit more into that, but also as the state mental health authority and the state substance use authority since we merged with the Division of Behavioral Health Services back in 2016. And so we not only oversee our Medicaid dollars, which is the vast majority of our spend, but we also oversee our SAMHSA, which is the Substance Abuse Mental Health Services Administration through HHS at the federal level. We oversee grants there that really have an ability to impact the way we service, our service delivery model works for opioid use disorder, including Narcan distribution that Sheila and Jessica had talked about, in that we're able to fund it through our community efforts. And so we managed both our substance abuse block grant from SAMHSA as well as our state opioid response grant. And so I'll give you some examples of how we're leveraging those additional fund sources to be innovative in the field of really responding to this horrific public health epidemic. So we can go to the next slide, please. So we have a pretty significant footprint for the opioid epidemic in Arizona. As right now, we have over 2.5 million, and it's just coming down as of April to just right under 2.5 million Arizonans enrolled in Arizona Medicaid program. So that's almost a third of our population in Arizona. So I see some public health participants in the call, and so from a public health perspective, really have the ability to impact this epidemic. We also have the ability to impact, substance abuse newborns as far as what that substance exposure looks like for both the child as well as the entire family unit, as we cover over half the births in Arizona. Also just wanted to note around as we're looking at infrastructure, including supporting our health care professionals, especially recovering from the COVID-19 pandemic and the challenges there, we have a huge ability to help support our workforce, including the expansion of providers that are able to provide the full continuum of services, of treatment services, including medication-assisted treatment for opioid use disorder. So we have over 120,000 providers that are enrolled in our program. And the vast majority of the way that we do business in Arizona is through an 1115 waiver, which basically means we have a lot of flexibility in how we implement our Arizona Medicaid program, which is through our managed care plans, including Health Choice, who's helped hosting this call today. All right, if we can move to the next slide, please. This just provides a little bit of an overview around how we do that. And just out of the interest of time, I'm going to skip over to some of the work that we're doing related to opioids. And so we can go ahead and skip over to the next slide, which shows our Medicaid population. And as I mentioned, we're starting to see some of the redeterminations within the Medicaid program. We had put a hold on disenrollment during the public health emergency and have recently started doing member redeterminations. And so we had anticipated to start seeing a decrease in Medicaid members that are enrolled in our program due to the lifting of that hold on redeterminations. Next slide. All right. So this is the fun stuff that I get to present on around some of the really innovative strategies that we have to address the opioid epidemic. And we really view it from not only the treatment side, but also really the preventative side. So if you can go into the next slide, it discusses the strategy. And the first and foremost, which I'm a very big believer in, is that primary prevention piece. And so we're very fortunate because we do oversee the grants from SAMHSA that we can actually spend dollars in preventing opioid use disorder. And I'll give one example that some of you have heard me talk about, which is the PACS Good Behavior came under Dr. Embry. And so the next slide will go into that. But I firmly believe as a child psychiatrist, as well as, the chief medical officer for our Medicaid program, prevention. And so we are helping to fund that in order to prevent the future overdoses, but also future opioid use disorder. In order for individuals to access care, one component that's critically important is reduction in stigma, because if we have blame and shame and use some of the words that we've used historically to describe opioid use disorder, then that's going to cause individuals to have reluctance to interface with our healthcare system. And I can say we've made great strides and great progress in the last 2-3 decades in regards to how we understand the complex interplay of the biopsychosocial model of addiction. And so part of our efforts is reducing stigma, including really educating healthcare providers and our healthcare community in regards to non-stigmatizing and really rehabilitative and language, understanding that people can enter into recovery. We've talked a lot about Narcan, or otherwise known as naloxone, and I'll go into a little bit more detail, but we are full court press on making sure we have a distribution model that saturates Arizona and making sure that Narcan is in the hand of everybody that needs it. And with the recent FDA approval of it being over the counter, we do think that's going to greatly assist as well. And then also wanted to add around that continuum from prevention to, intervention to an emergency, as far as an emergency condition necessitating Narcan, we also offer the full continuum of treatment services, including medication-assisted treatment. Next slide. All right, so one thing that I had mentioned on my previous slide is around prevention and primary prevention. And so work that we've been doing several years with Dr. Embry down in Tucson, Arizona, is around the PACS Good Behavior game. It's based on applied behavioral analysis, and it's implemented in first and second grade classrooms, although it has been adapted for both middle and high schools as well. But the most published research is on first and second grade classrooms. And for those that, are interested, Dr. Embry is a great resource and a great colleague to describe some of what that research base shows. But as you can see on this summary slide, which is one of my favorites, really an increase in pro-social based behavior as far as college attainment as well as high school attainment when first and second grade classroom students were followed longitudinally. But we're talking about opioids here today, and the pretty significant impact, as you can see, on kind of those behaviors we'd like to see a reduction in, including opioid use, saw a 64% reduction in those that were involved in first and second grade classroom implementation of the PACS Good Behavior game. So we continue to fund this primary prevention through our grants at Access and in partnership with the Department of Education. Next slide. Want to go through the next slides relatively quickly so we have time. I know Dr. Gibson's next around telehealth, but I wanted to kind of leave you with an impression of all the wonderful work we have underway, including our partnership with Department of Health Services. And so one of the areas is around stigma reduction. And so Department of Health Services has launched, through support of our state opioid response grant, a stigma reduction campaign in regards to women who use substances while pregnant or postpartumly. And so really trying to reduce the stigma in order to increase access to care and help-seeking behavior rather than this historical kind of blame and shame, which would prevent individuals from coming in and receiving health care. Next slide. Also wanted to note that in regard to looking at evidence-based care, including conducting quality assessments to determine and match our members to the right level of care, that we're currently in the process of implementing the ASAM continuum. So ASAM, which is the American Society of Addiction Medicine, several years ago copyrighted their criteria. And so the way that we're able to actually implement the criteria, the ASAM criteria, is through the continuum. So we're currently piloting it with multiple providers, which includes over 150 actual clinicians, both behavioral health technicians and behavioral health professionals, who are actually starting April 1st, starting to implement this, and we're going to evaluate how we can bring it to scale amongst all of our healthcare providers who conduct behavioral health substance use assessments within the state of Arizona. Next slide. For those that are not aware, we do have an opioid use disorder services locator on our website, and this is updated on a regular basis. And so it is up-to-date information around OBOS, which are those outpatient-based providers that provide Suboxone, for example, or naltrexone. It also includes our opioid treatment programs, OTPs, which have a full continuum of services, including methadone, and then as well as residential treatment and where you can find naloxone. So please feel free to check that out on our website. Next slide. One of the really innovative strategies that at that time, Shana Malone was part of my team in overseeing our state opioid response, a really innovative idea for really expanding the number of hours that our opioid treatment programs, OTPs, otherwise known as methadone clinics, operate. Typically, methadone clinics operate right before work, about 6 a.m. They usually close about 2 p.m., but the hours vary. Just knowing we were in the opioid epidemic, recognizing that many individuals will encounter the ED and crisis system after hours, including, in middle of the night. Shana had a great idea to expand the hours for 24/7 access to care for opioid use disorder. And so these are our 4 24/7 OTPs that currently exist in Arizona today, thanks to her great idea. All right, next slide. Wanted to say the efforts around medication assisted treatment, including making sure we have, both the right quality and quantity of providers, and also increasing the identification of opioid use disorder, that we have seen an increased trend of both opioid use disorder being identified within our system, and that's through the top line. So, and this is based on our claims encounter system through our Medicaid system. And so back in 2018, we had identified, 51,733 unique members that had a service claim within our system with an opioid use disorder diagnosis, and that has increased to over 71,000 as of 2021. And the bottom line, as far as that darker blue graph, is the percentage of those individuals identified on a claim who had an opioid use disorder that also had a claim for a medication-assisted treatment with methadone, Suboxone, or naltrexone. And so you can see the trend for the percentage that are receiving medication-assisted treatment has also increased over the years. And so we're tracking that, including current analysis underway for 2022. But it is demonstrating two things. Number one, that we are identifying opioid use disorder, an increase in our members who are receiving services, including an increase in those that are accessing the evidence-based treatment, medication-assisted treatment. Next slide. And then this slide just demonstrates the form of the medication-assisted treatment, whether that be Suboxone, methadone, or naltrexone. We've seen increase across the board. Our largest percentage is in methadone on that top line, followed by Suboxone, and then naltrexone. Next slide. Another resource for our communities is around our OR line, and this is something that Department of Health Services also helps support, and it's run through our Toxicology Center and the University of Arizona College of Medicine Phoenix campus. So if you haven't had a chance to spread the word about the OR line, it still is being funded and is a huge resource for anybody that has questions, including professionals as well as the public, around anything opioid related. Next slide. We also have significant naloxone programs, including distributed through our Department of Health Services, as well as community-based through Sonoran Prevention Works. And as Jessica mentioned, with it becoming over-the-counter, that's another great way. But the good news is with our the way that we're funding naloxone now, it's basically free for communities to actually get it. And so we're mindful of those strategies to make it at no cost to Arizonans. And so there's really two methods, either through DHS ordering or through Sonoran Prevention Works. And we have contact information for both if you're interested in ordering naloxone for free, because we're funding that through our grants. Next slide. We do have a strategy underway, and I did see we have one of our hospital associations on the call, and they're a great partner with us. But really, as people experience overdose or are at risk of opioid overdose, they encounter our emergency response system, including our emergency departments, and I have to give a shout out to this 6 emergency departments that are currently providing naloxone to individuals leaving their emergency room. And we have currently a differential adjusted payment coming in for 24, which basically means that we're offering additional funding to ERs and hospitals that adopt naloxone distribution program. So if you haven't had a chance and you're either an ER or hospital, there's a direct link to that if you want to sign up, and I encourage you to do so. Next slide. All right, this is my last one, so apologies for going a little over time, lots of information to get through. The last resource I wanted to make sure that you were all aware of is our Substance Abuse Coalition Leaders of Arizona, otherwise known as SACLA-AZ. Really, they're local coalitions made up of community members, really just trying to make a difference in their community. And we also help fund efforts through our state opioid response grant, and part of those efforts is community toolkits, including around stigma reduction, media campaigns, and so these are available via Dropbox through this hyperlink. And so it's an additional resource for those that are interested in learning more around how they can make a difference within their community. With that, I'm going to turn it over, I think, back to Jessica or Dr. Gibson.
Thank you so much, Dr. Salek, for those remarks. I think that was great and just phenomenal resources that you shared as well. For everyone on the call, we will be working on getting these presentations and this recording posted on the NARBA Institute website, and we'll be sending a subsequent email as a follow-up to this call that'll include links to some of those key resources too, if you didn't have a chance to capture them. Dr. Gibson, I'll turn it over to you now to share your comments. Thank you.
Hey. So thank you for pulling up my slides, Jennifer. You can advance. I am a psychiatrist who both works overseeing telehealth for all of northern and central Arizona, but as well as being in community psychiatry. And so wish to speak from both of those perspectives. In regards to this opioid epidemic that we're discussing today, my basic take-home points are what we can do to connect the people with the treatment and how can we support our providers. Next slide. So my passion is about telehealth and connection. We had this lovely COVID-19 public health emergency, and we were required to distance from our patients and from each other. And then we had a second epidemic, which we're talking about today, which is an increase in mental health and substance use disorder deaths and disability. And so my passion was that we need to connect however we can with our people. My clinic in Apache County closed its doors entirely and did everything over telehealth during the initial parts of the pandemic. So we had physical distancing, but with the use of telehealth, we can provide a social connection. And that is what we need to help access our people. Next slide, please. Through connection, we know that telehealth can increase access to care. This is how we engage people. It's been shown over and over that people can establish good relationships and good treatment outcomes over telehealth. And there was just a study in JAMA, Journal of the American Medical Association, in JAMA Psychiatry, about that persons who were treated during the pandemic over telehealth for opioid use disorders had a decreased risk of fatal drug overdose. So it sort of helped me to validate our use of telehealth. We also really worked on ways to get telehealth into places that didn't have good connections. So for instance, there's a thing called the digital divide, and that means people who don't have the resources to do a good data collection, or they have a phone, but they don't have a smartphone, or they don't have a computer, or they don't have a landline even, or they might have a landline, but they don't have a landline, but they have a cell phone, but they don't have data on their cell phone. So we came up with a lot of ways to access people remotely. And one of the best ones was to have tablets with data that we paid for. Actually, we got a grant from NARBA, thank you. And we were able to deliver those tablets to people's homes safely and do full telehealth interactions over the tablet. And we also got really good at doing group therapy and groups over telehealth. And that was a miracle in terms of helping our no-show rate, engaging people, interacting with people. And then last resort, if we couldn't get through to them with video, we had the telephone, and we are grateful to Access for making that very accessible to us, because there were times when that was the only way to reach people. And so we were very grateful for that. Next slide, please. So medications for opioid use disorder, we've been hearing about that, and they are effective in really reducing the risk of overdose and death. But many times the populations who are at elevated risk of death aren't the ones who can easily access healthcare settings, or they can't make it in for an appointment. And then that means they can't access their medications. The other big barrier for getting these medications out to the people who need them is something called induction, and I'll talk about that a little bit. Next slide. That brings us to this concept that is a little controversial, but shouldn't be. It's called medication first. And medication first is modeled after Housing First, which is a homeless assistance program. And there's 4 basic principles. There's many more, but these are the top. And the basic principle is that we get the meds to the patient as quickly as possible. So number 1, persons with opioid use disorder should receive pharmacotherapy prior to undergoing lengthy assessment processes or treatment planning. So the usual, come in for an intake, okay, 7 days for that, and then another month till you get in with your medical provider. We don't do that. We try to get them on medications as quickly as possible. And then we offer the individualized psychosocial treatments that are adjunctive to the medication-assisted treatment. And this is the most important part, is that therapy is not required as a condition of medications. I think in substance use treatment, we have a long tradition of, you don't go to group, or you don't attend your sessions, you don't get your meds. And that is exactly counterintuitive to keeping people into effective treatment, which is what improves outcomes. And then we want to continue meds as long as they're helping. So maintenance pharmacotherapy is delivered without arbitrary tapering or time limits. So none of this, you can be on buprenorphine, Suboxone is the other name. You can be on Suboxone for 3 months, and then we'll start tapering you off, or 6 months. Any of those rules do not apply, and they result in adverse outcomes. And that's what we want, is survival and retaining people in treatment. And so that's where the 4th concept comes in, that medications are only discontinued if they're worsening the person's condition. Next slide, please. The second barrier that often prevents people from coming in for treatment is what we call induction. And induction is fairly unique to opioids, but it means that somehow we have to transition them off of whatever they're addicted or using inappropriately onto something that's safer. And in our world, we have 3 medications that we use for opioid use disorder. We have buprenorphine, methadone, and naltrexone. And methadone is only able to be used in a SAMHSA certified opioid treatment program, so I'm not going to talk about that. And naltrexone just doesn't have the uptake with the population that we would like. And it's frightening because a lot of people know that they have to detox entirely off of their opioid prior to starting it, and they have to be abstinent. Otherwise, they have this thing called precipitated withdrawal, which is the uncomfortable part of induction. So I won't talk so much about that, although it's a wonderful medication once people are already off their opioid. So then we'll talk about buprenorphine induction. And buprenorphine is an opioid, but it is a substitution therapy. So it is an opioid, but we're substituting the scary opioids like heroin and fentanyl and pills and whatever else they're using with something that's safer. Next slide, please. And so the big innovation here that has been around a long time, but became dramatically used once the pandemic started, is called, and I lost my extra word on here, but unobserved induction. So we've always had a tradition of an office-based induction, and that is where a patient gets their, they have their previous appointments and they get all the instructions and what we're going to do. They go into partial withdrawal, and then they go get their medications either through the office or filled at a pharmacy. They bring their medications in, take them in the office, and then they sit there in the office and are observed in the office as they go through this induction process. Well, in a home-based induction, that is known as an unobserved induction. And that is the current community standard of care, and a little bit different than we're used to doing it. However, it is safe. We have good studies back to 2009 that it is a safe method of giving this induction. And the ASAM's National Practice Guideline Committee consensus even supported it back in 2015. So it's really not new. And we're really seeing that it is the effective and safe way to blanket and get access to this treatment for more patients. The thing we have to remember is opiate withdrawal is not dangerous to adults. It feels terrible, but it's not dangerous. And so the whole home-based induction is really not as scary as it might seem. The biggest risk, though, is what's called precipitated withdrawal. And that is where somebody is on opiates and we give them buprenorphine and that whomps them into withdrawal. That is very uncomfortable and can be frightening. And so we have to educate the patient that they have to already be in partial withdrawal before they start that first dose of buprenorphine, presumably at home. And so that education piece is key, but that can be done easily. And we just give them this education. We talk with them ahead of time. We give them a prescription. They go to the pharmacy, they fill it, they take it home, and they can do the induction at home. Next slide, please. So if we have the ability to do an induction at home, then there's no wrong door. There's way more places that we can be doing this intervention. So jails, prisons are ideal places. We're starting a program with our jail in Apache County right now, finally, yay. PCP offices, primary care providers, they can be providing this. Releasing people from the emergency department is a very fabulous way to get people induced in onto the treatment that they need to save their lives. This is my passion, is those who are homeless, the person under the bridge. How do we get to them if they're not going to come into the clinic because they don't have transportation or they live under the bridge? So we can do these things wherever they are, and those who are homebound. Next slide, please. So that was about how we worked on connecting with the people with the treatment. The second part of this is prescriber support. Dr. Erin Goldman has this collaborative care committee through Health Choice that has been one of the places that we really have been able to reach out to our providers. You probably know that the DEA no longer requires the buprenorphine data waiver and XDEA number to be a buprenorphine prescriber. So that theoretically should dramatically increase our access to practitioners. However, practitioners are not coming on board as fast as they could be, and that's because they're intimidated. There is so much mythology over the buprenorphine data waiver and the fancy training and what is an induction and all those scary things. And they kind of just worry about their liability. And so by two things, mentorship and then training, we're trying to really reach out to providers to get more people on board. This is a great recommendation from Dr. Teresa Birch, which is, let's just get back to residency. It's not that scary. See one, do one, teach one. And that's how you do an induction, and it's not that hard. And we can train on evidence-based practices in our committees. And then we also have had a lot of advocacy on the new DEA rules that are coming out, and on telehealth. And because of that, in our committees, we're able to have a lot of great conversations and help. Next slide, please. And then our other support for our providers has been through our Mountain Echo program. And Project Echo is a multidisciplinary tele-mentoring program involving lots of different disciplines where we get together. In our case, this is our substance use disorder Echo, the Mountain Echo, which has been going since March of 2018. And we get together right now twice a month. We have a brief lecture, and then we have a case presentation, and all of the disciplines get together and talk and give recommendations and support providers in providing treatment for substance use disorders. And this has been magical. I can't even tell you how much I've learned from this process. And I'm on the hub. I'm supposed to be one of the teachers theoretically, but that's not how we learn. We learn through the conversation. I will stop there. I've got in the slide deck, there's resources that you're welcome to refer to, and some more information on induction and the Echo if you're interested. Thank you.
Thank you so much for those remarks as well, Dr. Gibson. I think those were some great insights into some of the questions we've had and thoughts that people have about reluctance to prescribe MAT as well. I would love to invite Dr. Chatwal, with her depth of knowledge on all of these topics, just to reflect on what she's heard today and see what questions or thoughts this has brought for her. Dr. Chatwal.
Thanks, Jessica, and thank you to all the presenters. I feel like as a board certified addiction medicine physician, I too learned so many things, especially around what Arizona is doing, and especially Arizona Access and DHS and the resources that are provided. I especially wanted to, I think, speak to the breadth of services that are being used in Arizona. I think from a primary prevention as well as some secondary prevention and harm reduction avenues. And I was really impressed myself and grateful that so many amazing minds in the state have been working on this. In spite of that, I couldn't help but notice that the trend really has been that the number of opioid overdoses as well as opioid deaths are continuing to increase in the state. And I wanted to try and see if our panelists had any thoughts if this is really because there's been some reduction in stigma and we're screening more and people are identifying these issues more, or if you think that there's also just truly an increase, and oftentimes it can be a mix of the two. But wanted to invite your thoughts in where you see this trend going over the next couple of years with all the interventions that we're trying at the state level.
I'm happy to kind of comment first, Dr. Chatwal. Thank you for that. I think it's definitely changed in regards to what we're seeing, and I think the biggest concern right now is related to the influx of fentanyl into our streets. And so, you know, definitely Sheila can speak more around those data trends, and you can actually filter on the opioid dashboard on the DHS website around looking at substances related to overdoses. But I think the biggest concern I have from a public health perspective is that fentanyl is basically in our neighborhoods, and it really is a law enforcement now issue in regards to how do they seize the influx of fentanyl. And so from a public health, public policy perspective, our role is to first communicate to all of our community members that fentanyl is in our drug supply and that it is fatal when taken because of the high potency. And so educating our children, educating our adults, again, Sheila showed that adult range, but we are losing kids too to fentanyl overdose. And so really educating everybody in our community, and that's where SACLA AZ comes in, because the scope of this issue has changed, and it's changed because of fentanyl in our drug supply. And so I think community education, awareness, and then getting naloxone in the hands of everyone and understanding that it's not just naloxone, it's also activating EMS. So then stigma reduction does come into play in regards to decriminalization, and that also decrease risk associated with activating law enforcement based on the concerns some of our community members have. So I'll turn it over to my other colleagues to see if they'd like to expand upon that.
My other thought, just working with people, I totally agree about the fentanyl. It's terrifying, and people don't know or don't realize or think it's not in my backyard, and it is. I literally found a packet of something in my yard. Yep. And I don't know what it was, and I just laughed. But I think one of the interesting things that has happened is we've worked really hard as a society and as medical professionals to decrease how many opioids we're prescribing to people, and benzodiazepines as well. And I think that is so important. But also what I'm hearing is that, well, then I'm just going to have to go to heroin. And you're just, oh no. So, we have to be so therapeutic in our approaches to how we are addressing use disorders of all kinds, because if we just panic and cut people off from what they've been on forever, rather than a targeted therapeutic withdrawal and actually treating the pain or whatever it is that, or the anxiety or whatever it is that they're using these things for, then we just get increase in the riskier and scarier things that are out there that people can access horrifyingly easily.
Just quickly to the naloxone, excuse me, quickly to the naloxone question, Dr. Salek, there's a question in the chat about whether the hospitals that you shared that have the naloxone program provide those to walk-ins as well, or is that just an ED discharge program for naloxone? Yeah, great question. And so really we do, I think it's not a one-size-fits-all, right? And so there's multiple ways to get naloxone. One way is to get a prescription from your provider and get that filled at the pharmacy. Another way is through our community distribution, both through Department of Health Services as well as Sonoran Prevention works. And so that's really our, I would say Sonoran Prevention works and kind of where folks can walk in and get naloxone. That's kind of our community distribution, whereas our ERs really is around individuals that have come in and are stabilizing status post-overdose. And so that would be not a walk-in center, but really more in reaction to the members that are coming in to receive care.
Thanks, Dr. Salek. I think there's another question in the chat that maybe we should take, Jessica, and I can read it out. It asks, in relation to prevention, it has been difficult in finding psychiatrists that start adolescents on MAD. I wonder if you have resources or a list of providers, or if that is something we should put together. I also feel that many detox facilities do not continue MAD, and I wonder if any interventions around this from the top would benefit. So I see that as sort of a two-piece question, and I know you shared that service locator in your slides, Dr. Salek. So if you want to speak to that, and then I'll let you take the second part if you'd like, you and Sheila.
Sure, yeah, happy to, and both great questions. So number one, yes, we need more providers that specialize in treating adolescent substance use disorders. And so we can do a better job with that. In fact, reflecting back in 2005 when I started my child fellowship at Boston Children's Hospital, we actually had a Suboxone clinic. So, we're looking at now 18 years ago. And so I know, gosh, is it that long? I know this is not new, and I think it speaks to what Dr. Gibson was saying. Like, we treat all sorts of complex health conditions, including for our pediatric adolescent, and this is no different than any other condition, right? Healthcare condition where we prescribe. And so I do think we need kind of a call to action. So kudos to that commenter. We do need a call to action for more providers to get comfortable in the space of treating substance use conditions in adolescents. We do see a network challenge there. And so looking to my team to also leverage our substance abuse block grant and state opioid response grant to improve the access to care for our adolescents with opioid use disorder. And as noted, we do have that treatment locator, Dr. Chatwal, and one of the variables that you can look at is like adolescents, and so you can go in, put a zip code in, and also select adolescents. And I actually did so while we were chatting, and we've got some work to do around that. And so look forward to working with you all in helping us develop more providers that provide quality care to adolescents with substance use disorder, including medication-assisted treatment. And then the second part of the question was around detox. And this has been an issue for years, right? Detoxing for just the sake of detoxing and just this revolving door. It is an issue and is one that we do take seriously. It's definitely at the level of, at the national level, including with SAMHSA. And we know with opioids that it's just not as simple as detoxing, right? It requires really a complex biopsychosocial evaluation and comprehensive care. And so detoxing just for the sake of detoxing is not part of that comprehensive care package. And so if there are kind of quality of care concerns, if there are providers within, for example, the Access Network that folks are concerned about, we definitely want to hear about that. I had mentioned at the very start, we leverage our managed care organizations, including Health Choice, to really contract with a quality network. And so one of the great things about our managed care organizations is they have the ability to contract with preferred providers that are doing that good quality care. And so I'll leave you with that as well, is that we want to hear if there are providers that are providing substandard care, then we have mechanisms, including quality of care review, where we can explore that.
I think one of the places we see that a lot are after detox in residential group home and residential substance abuse treatment centers that actually have policies. If you're on buprenorphine, you're not sober and you can't be in our facility. And so we try to outreach those. Sometimes though they're not licensed and they're not through Access, and we can't find ways to enforce that. So it's just about continual education and desperation, and just keep swimming, just keep educating, just keep teaching, just keep supporting all of our placements in how to keep going.
Thank you so much for those comments. Dr. Chatwal, I'd love for you to kind of round us out with a last comment before I share some logistics about getting CMEs. Any last thoughts that you'd like to share as we close out?
Thanks, Jessica. I think I, again, really like the discussion. There's a little piece on, fentanyl test strip distribution in the state that is definitely being done, that folks should learn more about and make sure that they're aware of. And I really liked one of Dr. Gibson's comments around the anxiety, depression, and other mental health conditions and how opiates play a role. And I think maybe that's a little less discussed topic around how folks are using opiates, not just for physical pain, but also for the psychological and emotional pain. And so a lot of the times when we're seeing folks who are seeking treatment, or even if they're not seeking treatment and using opiates, we're needing to make sure that we're doing really thorough trauma and mental health screenings as well, because they could be using that as a psychotropic agent rather than just the pain treatment. So pain can be of that psychological nature, and appreciate everybody in the state who's doing a lot of great work. We thankfully at Sierra Tucson have over 20 buprenorphine providers, so I also felt good and wanted to pat myself on the back during the presentation. So thank you all.
Thank you so much to everyone for such a lively discussion today. We could spend an entire day on this topic, I know. As we conclude, though, I'd like to draw your attention to the QR code on the screen. This is where you can find the link to express your interest in obtaining CMEs or CEUs for today's talk and to provide any feedback on what you'd like to see in future sessions. And we'll follow up with an email survey too. Just a shout out to visit the NARBA Institute's website. You can sign up to be on the listserv for our Arizona Community Ground Rounds to be alerted of future talks. And save the date for June 7th. We'll be announcing a future Arizona Community Ground Rounds for then. Thank you all so much to our panelists. We are very appreciative of your time today and all of you who joined. We hope you have a great rest of your week. Thank you.